Hi there, my valued and highly treasured viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa, and I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for the healthcare sector workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal treatment outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services in your line of duty. So I would like to urge you to sit back and spare me part of your very precious time as I share some of the useful tips with you. So welcome back to part 23 of our Pharmacotherapy MCQ series. So in question 1, a 59-year-old Hispanic male presents to the clinic with a past medical history significant for coronary artery disease. Unfortunately, he has experienced or undergone 3 MI episodes. He is hypertensive and he has heart failure with a left ventricular ejection fraction of 35%. He also has dyslipidemia and suffers from type 2 diabetes. A very sick man indeed. He was seen by his family physician recently due to his uncontrolled hypertension, and he claims in his own words, and I quote, "A new drug was added to my regimen." Today, his chief complaint is increased shortness of breath and fatigue consistent with paroxysmal nocturnal dyspnea and orthopnea. He takes 40 milligrams of fosinopril once daily orally, 5 milligrams of glipizide twice daily after food, 40 milligrams of furosemide twice daily orally, 12.5 milligrams of metoprolol succinate once a day, 20 milligrams of pravastatin at night, and a tablet of verapamil extended release 240 milligrams once daily. Now, this patient cannot pinpoint which of the listed medications was newly added by his family doctor. So, in your opinion, which of the listed drugs is most likely to be the cause of his acute condition? Is it furosemide, fosinopril, metoprolol succinate, or verapamil? I'll give you 10 seconds to choose the correct answer. So verapamil it is, in my opinion. These symptoms are consistent with the heart failure decompensation, and they could be caused by 2 drugs on that list, either verapamil or metoprolol succinate. However, the verapamil at this given dose would most likely be the culprit drug, because it's most probably the one that he added for the BP control. Now, verapamil and other calcium channel blockers with negative inotropic properties are considered contraindicated in patients with systolic heart failure, since they worsen myocardial contractility further. Now, metoprolol succinate, on the other hand, if used aggressively initially, could also induce a decompensation via similar negative inotropic properties. But from the details that we've been given, he received it at a dose of 12.5 milligrams once a day, which is the recommended starting dose for heart failure. So it would be far less likely to have caused these symptoms. So personally, I would consider verapamil a culprit in this decompensation. Let's move to the next slide. A 67-year-old white male patient visits the clinic. He has a past medical history significant for hyperlipidemia, type 2 diabetes mellitus, and congestive heart failure, and is classified NYHA class 2. The echo reveals a left ventricular ejection fraction of 32%, and he currently takes low dose aspirin 81 milligrams once daily, 20 milligrams of lisinopril once a day, 10 milligrams of bisoprolol once a day. At the clinic, his BP is systolic 137, diastolic 80, and he has a heart rate of 64. And this patient denies symptoms of shortness of breath or any peripheral edema. His labs this morning are within the limits, with an exception of a slightly elevated BNP. So in your opinion, which of the therapeutic plans listed below would best suit this particular patient? Would you initiate spironolactone at a dose of 12.5 milligrams after breakfast? Or would you leave things as they are and continue with the same doses? Or would you initiate furosemide at 40 milligrams once daily after breakfast? Or alternatively, would you initiate a combination product of hydralazine and isosorbide dinitrate 37.5/20 milligrams at a dose of 1 tablet every 8 hours? I'll give you 10 seconds to choose the correct answer. So in my opinion, the best answer is A. I would initiate 12.5 milligrams of spironolactone orally once daily, in addition to what he's already on. Now, according to the ACC/AHA/Heart Failure Society of America Heart Failure Guidelines, aldosterone receptor antagonists such as spironolactone or eplerenone are recommended in patients with the New York Heart Association class 2 to 4 with an ejection fraction of 35% or less, and that is meant to reduce morbidity and mortality. And those are decisions that were made after conducting the what we call RAILS trial, RALES. Now, patients with class 2 should have a history of cardiovascular hospitalization or elevated BNP levels as seen in this patient for them to qualify for this modification. The patient doesn't have symptoms of fluid retention to warrant the use of furosemide at the moment, and addition of furosemide at this juncture will not contribute to mortality. So I would consider answer C wrong, and answer B is wrong as well because of the explanation I've offered. and the fixed dose combination in answer D is incorrect. It is recommended in addition to the ACE inhibitors and beta blockers to reduce morbidity and mortality for patients who are of African, American or black race origin and who also have class 3 or class 4 heart failure with a reduced ejection fraction. Our patient does not meet those conditions. Now, aldosterone receptor antagonists are also recommended in patients post-MI with a left ventricular ejection fraction less than or equal to 40% with symptoms of heart failure, or in diabetic patients with an LVEF less than 40, just for your information. The aldosterone receptor antagonist, spironolactone, in this particular case, has been associated with development of gynecomastia. And this happens due to non-specific blockade of androgen production, which increases estrogen levels. So it may be a bit problematic in the male gender. Now, in case it proves problematic, eplerenone could be considered an alternative to it. So that's just for your information. Let's move to the next question, which reads, ANM is a 22-year-old male patient who presents to the clinic with the fasting lab results listed below. The TC is 280, TG is 150, HDL is 55, and LDL cholesterol is 195. His renal and hepatic functions are both normal, and he tells you he follows a healthy diet and enjoys working 5 days weekly, a fairly active fellow. He doesn't smoke, and he tells you he takes less than 5 alcoholic beverages in a year. And when it comes to family history, he tells you his dad had a stroke at the age of 53. So I would like to ask you to choose the best therapeutic option for this gentleman from those listed below. Would you initiate atorvastatin, high intensity, at a dose of 40 milligrams on the lower end of the high intensity once daily at night? Or would you initiate pravastatin at a dose of 10 milligrams at night? Or do you think he should continue his current healthy heart failure style? He doesn't require medication? Or would you consider initiating aspirin at a dose of 325 milligrams once daily? I'll give you 10 seconds to choose the correct answer. So I would opt to put him on high intensity statin therapy, but on the lower end of 40, because it extends from 40 to 80 milligrams at night. In patients aged between 20 and 70 years with severe hypercholesterolemia, that is to say an LDL equal to or above 190, without calculating a 10-year ASCVD risk, it is appropriate to initiate high-intensity statin therapy to reduce the lifetime risk of ASCVD events. Now, according to the ACC/AHA lipid guidelines, basing on data from randomized controlled trials and cohort studies, they have shown clearly that statin therapy reduces risk of MI, of CHD, and all-cause mortality. Now, in adults aged between 20 and 39, we should consider certain therapy if family history of premature ASCVD exists, and if the LDL is equal to or more than 160 milligrams per deciliter. Now those facts make answer B incorrect. It is not an high intensity statin therapy, so I would not opt for pravastatin. Now pravastatin is considered low intensity statin when administered at that dose of 10 milligrams once a day at night, and guidelines highly recommend, as I said earlier, high intensity statins due to its greater ASCVD risk in patients who have an LDL of equal to or above 190. Now aspirin therapy in option D alone wouldn't provide sufficient risk reduction in this patient, so I would not settle for that. And the primary benefit of aspirin would be in secondary prevention. Now, while receiving maximally tolerated statin therapy and or have an LDL cholesterol of 100 milligrams a day or higher, I would consider adding ezetimibe also as a reasonable option, though it doesn't appear on that list of 4. That's just by the way. Let's move to the next question. Which of the following beta blockers is approved by the FDA for use in heart failure and is also known to reduce mortality associated with heart failure? Is it bisoprolol, Carvedilol, metoprolol tartrate, or atenolol? I'll give you 10 seconds to choose the correct answer. So Carvedilol it is. Carvedilol and metoprolol succinate, not tartrate like in option C, are approved by the FDA for the treatment of heart failure. That knocks off option C, and both metoprolol succinate and Carvedilol have been shown to reduce mortality in heart failure patients. Now bisoprolol, which is option A, isn't FDA approved for the treatment of heart failure, despite the fact that it has clinical data to support its ability to reduce mortality. So just like to emphasize that for that reason, because FDA has not approved it, answer A becomes wrong. And answer C is wrong because, as I said earlier, metoprolol succinate and not tartrate is the effective one according to trials that have been conducted, and it comes in a scored tablet form which can be broken into 2 in case you want to use half of the 25 milligram tablets, but you are advised not to crush such tablets. Let's move to the next question. Now, just like to emphasize that atenolol is not backed by any literature as being of any use in such patients. It's not approved by FDA, unlike Carvedilol and metoprolol succinate. So which statement below is accurate with regard to Esmolol? Does it belong to class 2 of antiarrhythmic agents? Or is it true that it has a long half-life, allowing for once daily dosing schedule? Or is it true that it can increase the pulse rate, or is it true that it's associated with causing drug interactions due to its ability to inhibit cytochrome P453A4? I'll give you 10 seconds to choose the correct answer. So in my opinion, A is the correct answer. Esmolol is a selective beta-1 blocker, which is also considered a class 2 antiarrhythmic agent with a very short half-life. That makes B wrong. It has a short half-life of 9 minutes, not a long half-life. Therefore, it has to be administered by a constant IV infusion, and it isn't administered once daily. So that makes B wrong. Now, due to its mechanism of action, it will decrease or slow the heart rate and not increase it. It doesn't inhibit CYP3A4, neither does it cause drug-drug interactions. And it's commonly administered with sodium nitroprusside for acute management of aortic dissection, just for your information. So all those facts are in favor of the fact that it is a class 2 antiarrhythmic agent and not one of the other three. Let's move to the next slide, which reads: a newly diagnosed treatment-naive patient with chronic stable angina belonging to the CSS class 2, according to the Canadian system, reports to the clinic for initial evaluation. If he has no contraindications to any form of therapy, which of the listed patient findings are correctly matched to appropriate pharmacotherapy in our patient's case? Is it an LDL of 143 milligrams per deciliter, merits initiation of Fenofibrate, or is it a BP of 145 systolic and 86 diastolic with a pulse of 52, merits initiating Carvedilol, or is it an LDL of 135, merits the initiation of atorvastatin, or is it a BP of 150 and a systolic of 96 with a pulse of 56, merits initiation of verapamil? I'll give you 10 seconds to choose the correct answer from that list. So I would opt for alternative C. Now, in both B and D, the therapies suggested are appropriate for blood pressure control, but the patient's pulses are low in both cases, and the use of either Carvedilol or verapamil in options B and D would further lower his pulse, which isn't optimal with the limited information that we have now. And atorvastatin is the most appropriate choice, that is C, when it comes to lowering LDL. Fenofibrate is generally used to reduce triglycerides, as it's the only it only has mild LDL lowering ability, and its data for morbidity and mortality improvement in coronary artery disease patients like this one is poor. So I would opt to initiate atorvastatin in a patient with an LDL of 135 and shy away from the rest. So let's move to the next slide. By what mechanism of action does Persantine increase coronary flow when administered in the cardiac stress test? Is it an A2A adenosine receptor agonist? Or does it inhibit adenosine deaminase? Or does it stimulate the beta-1 adrenergic receptor? Or is it a source of exogenous adenosine? I'll give you 10 seconds to choose the correct answer. So in my opinion, it inhibits adenosine deaminase. And this can cause vasodilation when carrying out that test. So what we call regadenoson is an A2A adenosine receptor agonist, which causes vasodilation. Now Persantine is the one that inhibits adenosine deaminase, reducing the breakdown of endogenous and underlying endogenous adenosine, causing coronary vasodilation. Dobutamine stimulates beta-1 receptor beta-1 receptors. Then adenosine administration is a source of provision of exogenous adenosine. When we inject it, it comes from an external source. That can cause short-lived vasodilation. Now that makes B our correct choice. That is to say, Persantine inhibits that deamination process of the existing or circulating adenosine. Let's move to the next question. A 41-year-old male patient was initiated on a new, in quotes, once-a-day medication for his hypertension about 28 days ago. And this patient is now complaining of bilateral lower extremity edema, and constipation also seems to bother him. So my question to you is, which of the medications listed below was he most probably started on? It doesn't seem to be clear. He has not forthrightly told you which one. So according to your clinical acumen, is it atenolol, lisinopril, chlorthalidone, or amlodipine, our calcium channel blocker? I'll give you 10 seconds to choose the correct answer. So in my opinion, amlodipine is most likely the culprit here. It is a dihydropyridine calcium channel blocker that is known to cause bilateral lower extremity edema, usually around the ankles and the feet. It also causes constipation and worsens reflux in patients with GERD. And it rarely causes gingival hyperplasia. That's a tongue twister, due to the ability to block or to impair calcium-mediated smooth muscle contraction. And that happens in blood vessels in the lower esophageal sphincter. That's why it affects those people with GERD, and in the GI tract. That is what causes the constipation. Now, calcium is required intracellularly by actin and myosin when they interact for muscular contraction to occur. Now, when it is blocked for this interaction between the actin and myosin, there's a reduction in that interaction and the smooth muscles relax. Now, atenolol in option A is a beta-1 selective blocker, which is associated with hypotension and bradycardia. It can cause heart block at high doses. It can lead to fatigue and dyspnea due to bronchospasm, which is a side effect. And less commonly, it can cause sexual dysfunction in the males especially. And then chlorthalidone in option C is a thiazide diuretic, which causes increased urination, hypercalcemia, hyperuricemia, hyponatremia, hyperglycemia, and hypochloremic alkalosis. Then option B, lisinopril, is an S inhibitor, which is commonly associated with hypotension, dizziness, hyperkalemia, and a dry, non-productive cough. It can also lead to an increase in serum creatinine levels. It can cause acute kidney injury in the presence of a bilateral renal artery stenosis, and there are also remote risks of angioedema. So all this make amlodipine the best choice, and I would just like to re-emphasize that amlodipine has a half-life of 30 to 50 hours, which allows a once daily dosing schedule, and it can be crushed and still maintain its PK profile without issues. But we have to watch out for those side effects that could be a bother, especially in the very old population who are prone to constipation. Let's move to the next question, which reads, PBO is a 63-year-old male patient who is admitted to the ICU at your hospital with acute decompensated heart failure. He is currently on metoprolol succinate at a dose of 50 milligrams once daily, furosemide at a dose of 40 milligrams twice a day, and his pertinent labs include a sodium of 135, a potassium of 4.7, a BUN of 22, bicarb of 22, and the serum creatinine is 1.2. His BP is 96 systolic, 72 diastolic. He has a heart rate of 106. His heart is revving. He has a body temperature of 98.1 degrees Fahrenheit and a respiratory rate of 20 breaths per minute. A physical exam is pertinent for pulmonary issues. He has cool extremities with weakly palpable pulse. Now, after placing the Swan's-Ganz catheter, his PaOP was found to be 15 millimeters of mercury, and the cardiac index was 1.7 liters per minute per meter squared. So my question to you is, what would be your next best step in the treatment or management of Mr. PBO in your ICU? Would you infuse dopamine continuously, or would you initiate 80 milligrams of IV furosemide twice a day, or would you infuse dobutamine continuously, or would you infuse milrinone continuously? I'll give you 10 seconds to choose the correct answer. So I would go for a continuous infusion of milrinone. Inotropic therapy would be appropriate because this patient has a decreased cardiac output, which is below 2.2 liters per minute per meter squared, and that is in the setting of normal volume status. Now, milrinone is the best option due to the concurrent use of beta blocker therapy and pre-existing tachycardia. Dobutamine, however, would improve end organ perfusion in this scenario, but the presence of background beta blocker therapy would require aggressive titration over the effects of metoprolol, which is also being administered. And additionally, this patient is already tachycardic around 106, and dobutamine would be more likely to increase that heart rate. It would go beyond 106. That would be dangerous. It would increase it to a larger extent than milrinone. Furosemide doesn't appear necessary in this patient's case because we have not been given any signs of edema. I would consider edema absent, and we know that the PaO stands at 15 millimeters of mercury. Now, norepi isn't necessary due to the adequate blood pressure and the absence of a cardiogenic shock. In that statement, I don't see any signs of a cardiogenic shock. Then just like to emphasize that IV inotropes are preferred in acute decompensated heart failure patients who wouldn't tolerate vasodilatory therapy. Patients should be first assessed for left-sided filling pressure to ensure they don't fall into class 3, which are called the cold and dry, which may benefit from cautious fluid expansion and re-evaluation. That's just a principle I would like to remind you about. Then I would also like to emphasize that dobutamine may be preferred in those patients with relative hypotension with a systolic blood pressure below 90 mm of mercury. Our patient, I think, is slightly above that, and that is due to the vasodilation that occurs with milrinone. However, it is important to note that dobutamine can also cause vasodilation via beta 2 receptor activation, and that warrants monitoring of systolic blood pressure as well. So it would be cumbersome to go for dobutamine. Now, whenever possible, vasodilators are preferred in acute decompensated heart failure due to the deleterious effects of inotropes, which may include arrhythmia and MI. So that's just a by the way to back the point that I would opt for a continuous infusion of milrinone as opposed to the other three. Let's move to the next question. Patient PWW, a 77-year-old female patient, presents to the hospital with altered mental status. Her heart rate is 42. She has a systolic blood pressure of 80, diastolic 35, and she's maintaining her airway. The breaths are 16 per minute, and she has an oxygen sat of 95 on room air. Currently, she is taking the following medications: lisinopril 10 milligrams once daily, atenolol 25 milligrams once daily, metformin 500 milligrams once daily. Now, the A&E team has already administered atropine at a dose of 0.5 milligrams twice from the time she was admitted, and there's been no response, and they're having difficulty getting the transcutaneous pacing pads to capture, and because that is because the patient is overweight, 130 kilograms to be specific. It's an obese patient. Now, which of the following, in your opinion, would be the next best step or the next best action for the team to take at this particular juncture? Would they administer glycopyrrolate at a dose of 0.4 milligrams IV, Or would it be prudent to inject phenylephrine at a dose of 100 mics IV? Or would you settle for 0.05 milligrams of glucagon per kilo IV? Or would you administer dopamine at a dose of 2 mics per kilo per minute? I'll give you 10 seconds to choose the correct answer. Personally, I would be biased towards glucagon. Now, it is reasonable to use glucagon in patients with bradycardia while on beta blockers. While the ideal therapy is to establish electric pacing, the temporary transcutaneous devices don't always work, and it may take an extended period of time to transfer the patient to receive a pacemaker or other advanced cardiac management. Now, in my opinion, glycopyrrolate isn't an effective agent in bradycardia. It just reduces secretions in the airway, so I wouldn't opt for it. Although the patient is hypotensive according to those values, phenylephrine-induced vasoconstriction could worsen his afterload in increased stress on the heart. So I would not opt for phenylephrine. And the initial glucagon dose which I would administer is 0.05 to 0.15 milligrams per kilo, or I would alternatively opt for 3 to 10 milligrams IV once, followed by an infusion of 3 to 5 milligrams per hour. Now, what it does is to bind to the beta 1 receptors in a different location than the beta agonists, and that bypasses the effect, and it stimulates the adenylate cyclase to produce increased CMP. That may cause flushing, may cause nausea, may cause vomiting in a dose-dependent manner. So, if using it, there may be need to do close monitoring at bedside to prevent or avert any aspiration by the patient. But otherwise, it would be our best bet in this particular clinical situation or scenario. Let's move to the next question, which reads, which of the following best describes the safety with ezetimibe administration without statin therapy in dyslipidemic HIV infected patients who are already on highly active antiretroviral therapy? Is it true that comparable lipid lowering efficacy exists but with a greater risk for myopathy? Or is it true that less lipid lowering activity occurs than in HIV negative patients but with equal safety? Or is it greater lipid lowering than in HIV negative patients but with no differences in safety? Or is there comparable safety and efficacy to use in HIV negative patients? I'll give you 10 seconds to choose the correct answer. Answer here is D. Now, based on known LDL cholesterol lowering with ezetimibe alone, which stands at 18%, and in combination with statins at 25% in non-HIV patients, the preliminary data available supports similar efficacy without compromising viral immunological control and safety. Let's move to the next question, which reads, a 65-year-old man presents to the hospital with a past medical history of stage C heart failure with a reduced ejection fraction, what we call HFrEF. Is also hypertension and gout. and he takes allopurinol for his gout. He's also on lisinopril, aspirin, metoprolol succinate, and furosemide. Now, which evidence-based approach would you adopt in the modification of this patient's regimen to reduce mortality due to his HFrEF? Would you add amiodarone to the therapy, add digoxin, add spironolactone, or add chlorothalidone? I'll give you 10 seconds to choose the best option. So I would consider adding spironolactone. Now, spironolactone is our best option, and the next best intervention, since the patient has HFrEF and is already on appropriate initial therapy of an ACE inhibitor, a beta blocker, and a loop diuretic. Now, this patient, or this treatment, was studied in, I think, what we call the RAILS trial, which was stopped prematurely due to the significant benefits of using spironolactone in such patients. It would be wrong to utilize amlodipine, which is option. Okay, I don't see it there. It would be wrong to use amlodipine anyway in such a patient because the BP, if I remember well, is still not well controlled, and it would not be the next best step. Neither would it be appropriate to use amiodarone. That would control the rhythm. I would recommend we always use the treatments with clear mortality or evidence-based benefits as quoted in literature, and amiodarone doesn't seem to be one of them. Now, chlorothalidone is a thiazide diuretic. It could be added to existing loop diuretics, but only with intermittent use, not non-stop, for the purpose of getting rid of excess fluid. So I would not put it non-stop. Now, adding it on a daily basis to a loop diuretic without paying attention would result in the patient being over-diuresed, which may end up in acute kidney injury. We don't want to get there now. Now, digoxin doesn't reduce mortality like spironolactone does, but it could improve morbidity if we dose it correctly. So, in my opinion, spironolactone still stands as superior to digoxin. And then, just in case there are issues with the spironolactone, eplerenone could work as a substitute, but there are risks of dose-dependent hyperkalemia. There are greater risks compared to spironolactone, so I would use it as a last resort if for some reason or another spironolactone does not serve as well. Maybe there could be gynecomastia that a male patient is uncomfortable with. In such a case, I would opt for eplerenone, but I would watch out for hyperkalemia. Let's move to the next question, which reads: ASD is a patient with heart failure and he presents to the cardiac clinic. Currently, he's taking 12.5 milligrams of Carvedilol twice daily, according to the verbal interview you have conducted. And he inquires if there is a once daily formulation he can take to decrease his daily pill burden. There are times he forgets to take twice a day, so he would like a once a day regimen. Now, which Carvedilol extended release formulation dose would you consider equivalent to the regular release 12.5 milligram tablets he takes currently twice daily? Is it the 40, the 25, the 20, or the 12.5 milligrams extended release? I'll give you 10 seconds to choose the correct answer. So it's 40 milligrams, and I'll tell you why. Now, the extended release tablets have a higher molecular weight per tablet since they are Carvedilol phosphate as opposed to the regular form, which is a simple Carvedilol base. Now, due to this, the conversion from regular to extended release formulation isn't the traditional daily dose given one. So you cannot translate it to 2 times 12.5. That would be wrong. A total daily dose of 25 is equivalent to 40 milligrams of the extended release tablets, because it's a phosphate as opposed to pure base in the ordinary tablets. Let's move to the next question. Which of the drugs listed below is indicated for patients with homozygous familial hypercholesterolemia? Is it Fenofibrate? Is it Lomitapide? Is it Liraglutide? Or is it Saxagliptin? I'll give you 10 seconds to choose the correct answer. So Lomitapide it is, and Lomitapide is a microsomal triglyceride transfer protein, what we call an MTP, which is indicated for patients with homozygous familial hypercholesterolemia. Now, option C, Liraglutide, is a GLP-1 receptor agonist used in the management of type 2 diabetes mellitus. Saxagliptin, alternative D, is a DPP-4 inhibitor, also used to manage type 2 diabetes mellitus. Then Fenofibrate is used in the management of hypertriglyceridemia, but not homozygous familial hypercholesterolemia. So that makes options A, C, and D wrong choices in this particular patient. In the next question, lipid-lowering medication is initiated in a 46-year-old white male patient for his low density lipid cholesterol. He reports to the clinic after 90 days without complaints, and he confirms that he adheres to his medication well. His fasting lipid profile from the morning sample show an improvement in his LDL by 20%, but when you observe closely, you notice that his triglyceride has increased from baseline. So my question to you is, which of the drugs listed below could have caused this particular change? Is it Questran? Is it Zetia? Is it Rosuvastatin? Or is it the omega-3 acid ethyl ester? I'll give you 10 seconds to choose the correct answer. Culprit here is Questran, cholestyramine. Now, it is a bile acid sequestrant that can be used to lower LDL, and it's commonly associated with an increase in triglyceride. It isn't used in patients with elevated baseline triglyceride concentrations. So before you initiate this, you must have a baseline. And none of the other listed agents are known to significantly worsen triglyceride levels to the extent that Questran does. So I would settle for A as my best answer. Let's move to the next question, which reads, JPO is a 56-year-old male patient who is admitted to the ICU at your hospital to be managed for pneumonia. And he is currently on hospital day 4 and has been diagnosed with heparin-induced thrombocytopenia. Now, further investigations reveal a pulmonary embolism without hemodynamic compromise. His platelets are 55,000, PT is 13.1 seconds, the APTT is 28.1, and there is no evidence of acute hemorrhage when you examine closely. So my question to you is, which of the following would be the most appropriate pharmacologic intervention in this patient's case? Would you infuse agatroban at a dose of 2 mics per kilo per minute? Or would you administer 5,000 units of dalteparin subcutaneously twice daily? Or would you administer enoxaparin at a dose of 1 milligram per kilo subcut twice a day? Or do you think anticoagulation is contraindicated at this time? I'll give you 10 seconds to choose the correct answer. So I'd be comfortable with agatroban at a dose of 2 mics per kilo per minute via infusion. Now, although heat carries a risk of hemorrhage and thrombosis, there is currently no contraindication for our particular patient, Mr. JPO, to receive anticoagulation. And the ideal agent for treating a heat and underlying PR is agatroban. It is the first-line treatment in patients with heat. Now, when transitioning a patient from agatroban to warfarin, there are things we need to take care of. Adjustment and close monitoring is necessary since our favorite agatroban may prolong INR. In patients requiring less than 2 mics per kilo per minute of agatroban, the therapy can be stopped when the INR becomes greater than 4 on combined warfarin and agatroban therapy. Then we can repeat the INR measurements after 4 to 6 hours after stopping the agatroban, and if the INR falls below the therapeutic level, agatroban may be restarted at the same dose. Now, this procedure should be repeated daily until the desired INR on warfarin alone is obtained. So it's kind of a seesaw. It calls for patience in the part of a clinician. Now, in those patients receiving more than 2 mics of agatroban per kilo per minute, we should reduce the agatroban dose to 2 mics per kilo per minute and then measure the INR of the combination after 4 to 6 hours after that dose reduction. And you can stop the agatroban therapy if the INR of the combined therapy is above 4. Then after that stop, you repeat the measurement after 4 to 6 hours, and if it falls below the therapeutic level, you may restart the reduced low dose of the agatroban, and this procedure should be repeated until you finally obtain a suitable or desired INR with warfarin alone. So it's quite tricky, calls for patience. Let's move to the next question. Which of the mechanisms of action listed below accurately applies to Evolocumab, which is called Repatha? Does it inhibit the HMG-CoA reductase, or does it bind mRNA for the ApoB100, or does it bind to PCSK9, or does it bind bile acids? I'll give you 10 seconds to choose the correct answer. So C is the correct answer. It binds PCSK9. Now, Repatha is a human monoclonal IgG2 directed agonist, human proprotein convertase sub tyrosine kexin 9. It's quite a tongue twister, abbreviated as PCSK9. It binds to the PCSK9 and inhibits circulating PCSK9 from binding to the LDL receptor, and that also prevents PCSK9 mediated LDL receptor degradation, and also prevents permitting LDL receptor to recycle back to the liver cell surface. Quite a cumbersome mechanism of action. It is administered once monthly, sub-Q, as an adjunct to diet and other low-density lipid lowering therapies. That's just for your information. Let's move to the next question. Which classes of lipid-lowering drugs listed below are well known to reduce intrahepatic cholesterol and to cause an upregulation of LDL receptors on the hepatocyte, thereby causing an LDL cholesterol reduction of up to 60%? Is it the fibrates? Is it the EPA and DHA? Or is it the selective cholesterol absorption inhibitors? Or is it the statins? I'll give you 10 seconds to choose the correct answer. In my opinion, it's the statins, and they are the only class from the lists above with the ability to preferentially lower low-density cholesterol up to 60%. And they're the only ones that have been proven in clinical trials to reduce mortality as well. They reduce intrahepatic cholesterol levels due to their ability to inhibit the rate-limiting step of cholesterol biosynthesis. Yeah, they are HMG-CoA coenzyme reductase inhibitors, and they reduce its ability to facilitate conversion of HMG-CoA coenzyme A to what we call mevalonate. Now the mevalonate then undergoes a series of reactions that eventually form cholesterol in the body, but they inhibit the formation of mevalonate. Now, as a result of reduction in intrahepatic concentration of cholesterol, the hepatocyte upregulates low-density cholesterol receptors to the surface in an effort to pull in the circulating low-density cholesterol in the bloodstream so that it can be processed and used for various functions. Now, this reduction in cholesterol occurs from a reduction in production of intrahepatic cholesterol, and then indirectly from an increased uptake of low-density cholesterol from the bloodstream. Now, the reduction in concentration of low-density cholesterol in circulation reduces deposition and oxidation of the low-density cholesterol within the endothelial lining of the blood vessels, where it eventually becomes an atherosclerotic plaque unless checked. So that explains why they are very useful in cardiovascular disease. Let's move to the next question. A 35-year-old lady is newly diagnosed with the gestational hypertension. Her BP stands at 154 systolic, 93 diastolic, and she has a heart rate of 70 at the clinic. And then she tells you that when she measured the values at home, they were systolic 152, diastolic 96, and the heart rate then was lower by 2 at a rate of 68 to be specific, and she's currently 23 weeks pregnant. She has no medication. She's taking no medication, and she doesn't have symptoms such as severe headache, vision changes, or dyspnea. So my question to you is, which of the options listed below would be the best pharmacologic therapy for this lady? Her pressure is evidently high and we need to bring it down slightly. Would you opt to initiate lisinopril at a low dose of 5 milligrams once a day? Or would you initiate 100 milligrams of labetalol at a dose of 100 milligrams twice daily? Or would you initiate atenolol at a dose of 50 milligrams once a day? Or would you opt for the diuretic 12.5 milligrams of hydrochlorothiazide once daily? I'll give you 10 seconds to choose the correct answer. I would be comfortable with the labetalol 100 milligrams twice daily. It is the preferred antihypertensive during pregnancy. It doesn't reduce fetal blood flow and doesn't seem to cause growth restrictions, possibly because it has both alpha and beta blocking properties. Now, option A, lisinopril, which is an ARB alongside the ACE inhibitors, are contraindicated in pregnancy due to increased risk of fetal renal damage. I would not initiate lisinopril at this stage. It would destroy the kidneys of the fetus. Now, although atenolol in option C is a beta blocker, it has been associated with a low birth weight in babies and it's not recommended either. Then option D, the thiazide diuretic, I would be uncomfortable to use it in pregnancy because it may cause volume depletion, leading to fetal and maternal complications in the course of the pregnancy. And usually thiazides are considered either second or third line if labetalol or methyl dopa can't be used for some reason or another. Now, I would just like to re-emphasize that medications affecting the renin-angiotensin system are generally not recommended in pregnancy because angiotensin II is necessary for fetal development of the heart, brain, and kidneys. So ACE inhibitors and ARBs are considered pregnancy category X due to the increased risk of damage to those vital organs. So I would not consider using them in this particular patient. Let's move to the next question, which reads: a 61-year-old female patient presents to the clinic with a past medical history of hypertension, and she had an MI 1 year ago. Now, on the echo, you approximate that the LVEF is 35%. She's currently on 81 milligrams of aspirin taken once daily, lisinopril 20 milligrams taken once daily, and the lower end of the high intensity statin, atorvastatin 40 milligrams at night. Systolic blood pressure is 133, diastolic 80, and she has a heart rate of 84, and she denies any shortness of breath or edema. The lab values are within normal limits. So my question to you is, which of the therapeutic plans below would be the most ideal for this lady today? Would you initiate furosemide at a dose of 10 milligrams once a day orally? Or do you think no medication changes are warranted at the moment? Or would you increase the lisinopril dose to 40 milligrams once a day? Or would you initiate a low dose Carvedilol 3.125 milligrams orally twice a day with an intention of titrating upwards as tolerated? I'll give you 10 seconds to choose the correct answer. I would opt to initiate low-dose Carvedilol. Now, beta blockers such as Carvedilol are considered the cornerstone treatment for guideline directed therapy for HFrEF. Additionally, patients with a history of MI should be on beta blockers ideally. This patient had an MI a year ago. Now, the benefits of adding beta blocker include decreased mortality, decreased hospitalization, and improved symptom control. So Carvedilol would add a lot of value to this patient. Now, since the patient isn't on HFrEF goal-directed therapy, I would consider answer B incorrect. There is need for intervention here. Now, option A, furosemide is indicated in patients with evidence of fluid retention, and this patient is not experiencing any dyspnea, shortness of breath, pulmonary congestion, or pulmonary edema. Therefore, in my opinion, furosemide is not indicated in this case. So that leaves me with option B as the favorite one. Now, the ACE inhibitor like lisinopril are recommended in all patients with HFrEF. Now, this patient is already on target dose for the heart failure, and any further dose increase isn't warranted. You would just worsen the hypercholesterolemia. So I would not tamper with the lisinopril dose. 40 would be too high. Evidence-based beta blocker for treatment of heart failure include bisoprolol or Carvedilol, which I opt for in this case, or metoprolol succinate extended release, not the tartrate, but succinate extended release. So Carvedilol is a non-selective beta blocker and an alpha-1 blocker, and that its use results in greater BP reduction compared to metoprolol, succinate, and bisoprolol. And the last two are selective beta-1 blockers, and that's what gives Carvedilol an edge over bisoprolol and metoprolol succinate. That's just a by the way. So let's move to the next question. Which of the following statements describes the most ideal indication for prasugrel marketed as Effiant in patients with cardiovascular disease? Is it option A? It is known to directly inhibit the clotting factor 10A, or is it a prodrug, or does it reversibly inhibit the P2Y12 component of the ADP receptor, or finally, is it administered via IM injection? I'll give you 10 seconds to choose the correct answer. So in my opinion, both answers B and C are correct. It is an oral product with the ability to irreversibly inhibit the P2Y12 component of the ADP receptor. Now, clopidogrel and prasugrel are both prodrugs, while the third P2Y12 in receptor inhibitor, which is ticagrelor, Brilinta to be specific, reversibly inhibits the receptor. That's the difference. And ticagrelor is a reversible inhibitor. So because it inhibits the platelets reversibly, we need to dose it twice, unlike the other two that bind to it permanently, and that is it. They have to be dosed once a day. That's the difference between the two. So as a by the way, take note that Brilinta is once daily because it reversibly binds to the receptor, so it can dissociate and merit an additional dose so that the effects are sustained, while the other two bind permanently. So once they bind, that is the end of the story. And you don't need to redose, you administer them once a day. Let's move to the next question, which reads, you are managing a heart failure black patient at your clinic, and he's currently taking an optimal regimen of Carvedilol, lisinopril, and furosemide. He continues to experience moderate to severe heart failure symptoms despite this optimal therapy. So my question to you would be, what add-on therapy listed below has been shown to improve clinical outcomes, specifically in the black race, the Africans and the African Americans? Is it spironolactone? Is it digoxin? Is it losartan? Or is it a combination of isosorbide, dinitrate, and hydralazine? I'll give you 10 seconds to choose the correct answer. So in my opinion, D is the correct answer. Now the combination of isosorbide dinitrate and hydralazine has been shown in literature to improve survival in the African American population with advanced heart failure. It is important to note that isosorbide dinitrate starts at in the range of 20 to 30 milligrams, dosed 3 times to 4 times a day, which can be titrated upwards to a total of 120 milligrams daily. Now the hydralazine dose should be started low at 25 to 50 milligrams, thrice to 4 times a day, with an up titration to a maximum of 300 milligrams if the patient can tolerate it. So that brings us to the end of part 23 of our Pharmacotherapy MCQ series. My esteemed viewers and listeners, I'm very grateful you made time and sacrifice to view and to listen to this video. And if this video helped you in any way, I would like to remind you to give it a thumbs up, to like it, and if you haven't done so, I would like to urge you to subscribe to my YouTube channel. And I would like to promise you and reassure you that the best is yet to come. Thank you for listening and for viewing, and I hope and look forward to interacting with you in part 24 of this series. Thank you for always being there for me. So my highly esteemed and cherished listeners, that brings us to the end of part 23 of our Pharmacotherapy MCQ series. Now, if this video helped you in any way, I would like to remind you to give it a thumbs up and to like it. And if you haven't yet done so, I would like to urge you to subscribe to my YouTube channel. I highly appreciate the fact that you sacrificed and made time to listen to and to view this video. And I look forward to interacting with you in part 24 of the series. Thank you for always being there for me.